first thing you need to get is classification first. Okay, classification is very, very important. When we are talking about white blood cell disorder, benign proliferation was in previous class, right? We have benign proliferative disorders and malignant proliferative disorders. Benign leukocytosis is, for example, when you have um, leukocytosis, different type of leukocytosis. We have lymphocytosis, and so on. And when we are talking about malignant one, in malignant one, you need to pay attention that we have leukemia and lymphoma. Malignant proliferation of white blood cell disorder is named with leukemia and lymphoma. And actually, there are two main types of malignancies, right? And different classifications of it. Different classifications means what you see here. Mm, uh, Leukemias, usually two major classifications. We have leukemia, acute leukemia, and chronic leukemia. But before we go to this is final classification, whatever you find in whole white blood cell disorders, this slide. But before that, we have other types of classification as well, and this can be classified like this. Leukemias are acute leukemia, chronic leukemia, and myelodysplastic syndrome. Lymphomas, we have two types, Hodgkin lymphomas and non-Hodgkin lymphoma. That is broad classification. If you understand classification, guys, then other part is really easy, okay? And third part is plasma cell disorder, and major disorder here is myeloma, multiple myeloma. Here comes another classification from different side. If you look this, we can classify this malignant proliferations based on myeloid vs lymphoid grouping. Myeloid malignancies can be classified acute myeloid, chronic myeloproliferative disorders, and myelodysplastic syndrome. Lymphoblast cell malignancies are T cell and B cell. Okay, T cell and B cell. Acute lymphoblastic non-Hodgkin lymphoma, myeloma, and T cell malignancies. T cell malignancies is this. Anyway, this classification, actually, this classification is different, but it comprises the same disorders. Okay, it depends from which side you look these diseases and what is easier for you. Okay, for me, for example, this classification is more comfortable for me when I was student. This classification was easier to understand. But broad classification, if you see now, these leukemias, what is nowadays, what classification we use is acute vs chronic. And here, please pay attention that acute leukemias, we have myeloid and lymphoblastic, right? Two lineages of cells. We have myeloid cells and lymphoid cells. So this acute leukemia actually will be based on these two groups. But when we are talking about chronic leukemia, pay attention that we don't say this group in this grouping, we don't use chronic myeloid leukemia and chronic lymphoid leukemia. No, actually, you should know that here is used chronic myeloproliferative disorders and chronic lymphoproliferative disorders. And these disorders comprise different groups of diseases. Four diseases are here are involved in these chronic myeloproliferative disorders. We will discuss these four diseases, and you should know how they are different. And in chronic lymphoproliferative disorders, we have also this chronic lymphocytic leukemia. Here is a leukemia, lymphocytic leukemia, and here is not written, but here we have as well mycosis fungoides. Okay, this is type of lymphoma. It is not written here, but I want to tell you one subtle detail as well, that lymphomas and leukemias are used interchangeably. Okay, these names, because we have some diseases that can be lymphoma as well as leukemia. For example, you see chronic lymphocytic leukemia here. This is same as small lymphocytic lymphoma. And small lymphocytic lymphoma you find here as well, guys, in which group I don't remember, but in lymphoma you will find as well. But you know, when we are talking about chronic lymphocytic leukemia and we talk about small lymphocytic lymphoma, you should know that they are same, okay? Same pathology, same pathogenesis, everything, but just two forms of disease. That is about classification, guys. If you understand the classification, then it is easy. Okay, today we will discuss from acute leukemias. We will discuss acute myeloid leukemias, different forms of it, and we will talk about lymphoblastic leukemias. Just to start, my darlings, wait, did I share a presentation? Wait, guys. Presentation is here. Just a moment. Okay, this one. Sorry, guys. I was at a different slide, PDF file. Okay, what you see here, again, I will tell in short, don't get confused. What you see here, this is classification, what is discussed in pathoma, guys, okay? And you see here is acute, chronic, and myeloproliferative disorders. And what I was talking about, this is one classification based on leukemia vs lymphoma, and leukemia is proliferation of white blood cells in bone marrow, and lymphoma is proliferation of these blood cells in lymph nodes. Okay, lymphoma is oma, means mass. So lymphoma you find in lymph nodes, and leukemia you find in bone marrow and peripheral blood. Okay, and leukemias we have acute chronic myelodysplastic syndrome, and plasma cell disorders we have as well, and myeloid vs lymphoid. That is also very useful classification, what I like, as I mentioned. What you see here, that is broad classification what you have in Robbins. You don't need to read Robbins, but I put here just these schemes, okay, to have big idea, big picture about white blood cell, nerve blood. White blood cell neoplasms again are divided in leukemias and lymphomas. Leukemias are lymphoid, myeloid. As you know, we have two lineages of the cells, and each of them is divided with acute and chronic. And lymphomas, we have only two. This is latest classification. 3 times changed this classification of hematology and white blood cell disorders. And final classification, it is Hodgkin vs non-Hodgkin disorders. That is what I was talking about, guys. That is, do you remember I mentioned myeloproliferative disorders? If you say here acute leukemia, acute myeloid with acute lymphoblastic, when you are talking about chronic processes, you should use myeloproliferative, okay? We don't use chronic lymphoid myeloid leukemia or chronic lymphoid leukemia. We don't use this. Myeloproliferative you should use, okay? That is myeloproliferative. It encompasses 4 disorders, as I mentioned already, here as well, and mycosis fungoides is in this group as well, because it is lymphoma, but you know, same pathogenesis it has, so we can include mycosis fungoides here as well. That is myeloid leukemia. We will start with the discussion of acute leukemias, actually. So major and most useful classification, what we use and what disorders we need to know, is given in this slide. Okay, so now that is more detailed grouping. Okay, when we are talking about acute and chronic, what it means. Diagnostic approach. I like this slide. It is very helpful, and follow this slide. When we are talking about these leukemias, what we need to make that we take this peripheral blood smear, right, and bone marrow biopsies for confirmatory diagnosis. If you see in blood smear blasts, guys, then you should count these blasts. How can we differentiate acute leukemia vs chronic leukemia? Based on number of blasts. If you find blast more than 20%, it will be acute. And if it is less than 20% and majority of cells in the peripheral blood smear should be matured white blood cells, okay, then it will be chronic leukemia. But if you find blast, it is acute, okay? So differential diagnosis here is based on number of blasts. Here is given. Now go to acute leukemia. In acute leukemia, if you have, okay, you found this more than 20% blast. What you are looking then? You need to differentiate, guys. Either it is lymphoid or myeloid lineage. Okay, how do you know it is lymphoid or myeloid? You look to this marker, okay? TDT, you see, TDT, actually what is TDT? TDT, guys, is a molecule that we use, we find only in blasts because it is the DNA polymerase, if I remember, yes, it is DNA polymerase, and you find in nuclei usually. Okay, and only in blast. TDT you don't find in any immature cells, you don't find, and you don't find also in T, in myeloid lineage cells. Okay, that is very helpful diagnostic molecule. What else, guys, you need to know? TDT is positive. Okay, then if you find that it is lymphoblastic leukemia, then you need to find out is it B cell or T cell ALL, right? Because you know that lymphoid cells, we have two lineages, B and T. Pre means, guys, they are matured forms. We are talking about blasts, right? So they are pre-immature cells usually. Markers are different, and you should pay attention to the markers. If you are talking about B cells, guys, in B cells usually, most commonly, the many markers you will have to memorize here. I will send this handout, and you will find the list of markers, and it will be easy to understand. So CD20, wherever you find CD20, please make sure that it is B cell. Okay, also CD10 and 19 are positive there. And if you are talking about T cell, in T cells, guys, actually a differential diagnosis means CD10 you should not find in pre-T acute lymphoblastic leukemia. Okay, CD10 you can memorize here. It is very helpful. And also CD2 is positive. These markers are positive. Yes, 1, 2, 5, 7 is positive. Also 8 is positive, guys. So many CD markers are positive. So it will confuse you. But make sure for exam purposes and clinical cases we will solve and practice, memorize that CD10 should not be positive in T cell, okay? And CD10 is positive in 20, in the B cell. So T and 10 and 20, you see, 10 and 20 can help you to differentiate between B and T. Now, when we are talking about AML, acute myelogenous leukemia, here comes different types of AML, okay? Different AML, we have different classification, guys. WHO classification of acute myeloid leukemia is you see 5 AML we have, and different mutations you will find. Some AML is related to drug, some AML is related to myelodysplasia and not otherwise characterized. They are non-specific AML. So many forms of AML we have. What I want to tell you from this slide actually is that is, guys, slide of acute leukemia. Okay, acute. What means acute? This is blood smear, and you see here red blood cell disorder. This is lymphocyte, and you see blasts in this one high power field. You find 1, 2, 3, 4, 5. 6, 7 blasts you should find. That means definitely acute the lymphoblastic leukemia, because do you know when we say leukemia is acute, you should have more than 20% blast. What you see here, this and this, uh, do you remember in this slide we talked about when you make a diagnosis of acute leukemia, you need to differentiate. Is it lymphoblastic or lymphoblastic or myelogenous? Okay. In TDT, it's very important. You find it only blast, lymphoblast. You don't find in myeloid cells, and you don't find also in matured lymphocytes. TDT you find only in lymphoblast. Now, how can you know that patient has myeloblast? MPO. MPO, guys, is myeloperoxidase, okay, myeloperoxidase that is positive in only myeloid cells. And how do we know? How we measure it? You can find it with chemical studies, and sometimes what happens is myeloperoxidase crystallize in the cytoplasm of blasts, okay, crystallize. And how it looks actually, you see, this is blast, myeloid blast, and how do you know? Here you should find 2-hour rods. When this myeloperoxidase crystallize in the cell, you should find hour rods, okay? You see, this is 1 hour rod, this is second hour rod, okay? 2-hour rods you find here. This is phagot cell you find in acute promyelocytic leukemia. This is M5, okay? This is AML5 here as well. No, we'll talk about it. APL is acute promyelocytic leukemia, and multiple hour rods you should find, and this cell is called phagot cells, okay? You will have this. And also, guys, you see AML, we mentioned that we have acute myeloid leukemia. It should be positive for MPO, hour rod, and we have different subclassification. Different subclassification. But before that, you should know that we are talking now about acute leukemia in general. When we are talking about acute leukemia, you should know general clinical signs and symptoms. How do you know? Okay, you found blasts, and you should know clinical signs and symptoms. What happens actually? What is the problem in acute leukemia? Problem in acute leukemia is tumor cells lose ability to mature. Okay, this blast lose ability to mature, and for that reason they pile up, right? And if you don't have, it depends which lineage of cells are affected, you will have appropriate clinical signs and symptoms. And what is this appropriate clinical signs and symptoms? For example, you have acute leukemia, which impairs bone marrow, the formation of red blood cells. You will have anemia. If platelets cannot be formed, like we have acute megakaryocytic leukemia, then you will have thrombocytopenia and you will have bleeding finally, right? If neutrophils cannot be formed, you will have neutropenia. And what is the complication of neutropenia? What is complication? Neutrophils are involved in inflammation, right? It defends us from infection. So people with acute leukemia who has problem with neutrophilic lineage, myeloid lineage, they will have secondary complication of infectious disorder. Sepsis usually can be complication in this case. Also, guys, anemia we mentioned. If you have loss of red blood cells and people with acute leukemia have anemia, they have second symptoms, no specific symptoms of hypoxia. Okay, hypoxia will be there. Thrombocytopenia will be followed bleeding. Neutropenia will be followed with infection, and the most common cause of death usually in this leukemia is infection. Okay, most common cause. Um, Also, guys, when we are saying that leukemia is acute means one thing, you find blast, and second thing, it has sudden onset. Okay, acute leukemia usually starts all of a sudden, and with these symptoms, and you will find multiple blasts in the cells. And blasts usually, you know how they look. They are big cells with very beautiful. So there is this sign. This is blast, very beautiful color of nuclei they have. You see, it's beautiful picture. And actually, if you see blood smear of acute leukemia, it is really, really beautiful, exactly. Literally beautiful some slide, okay, the colors and shape and everything. And we call it beautiful cancer, but if you find that you find this nice looking cells, that means it is very, very aggressive. So you see, I like it very much. So that is about blast and clinical signs and symptoms. Generally, anemia you should find, neutropenia you should find, and this bleeding and infection and everything is it characteristic to acute anemia, acute leukemia. Okay. Now, let's go through in more detail to acute myeloid leukemia, what you need to know. Different types we have. In Pathology, guys, you don't have this classification, and this classification is quite high yield. For that reason, please prepare this this difference between M3, M4, M5, seven groups of acute myeloid leukemia we have with different translocations. I sent this presentation as well as handout, and please prepare from it, okay? Multiple hour roads. Do you remember I mentioned these multiple hour roads is Fagot cells and are seen in M3. Different markers we have, I will talk about it. And what else is here in detail, I will discuss it. This is lymphoid. Now I'm talking about myeloid. About myeloid, what you need to know, guys. Myeloperoxidases, you understand. Also, guys, acute lymphoblastic leukemia usually has, myeloid leukemia has bad prognosis, actually, okay? It is not, it is quite aggressive. By the way. And why it is aggressive? Because most commonly you find it. One type is, for example, you should find in teenagers. Okay, teenagers. Mm, uh, and the clinical symptoms is diverse, quite diverse is clinical symptoms. And why it is diverse? Because we have different groups, right? And mostly this acute myeloid leukemia you find in older patient, unlike ACL, ACL and ALL we have. ALL, acute anyway, I get confused there as well. Acute myeloid, yes, acute myeloid, you find in elderly. And acute lymphoblastic leukemia, ACL, you find in children, guys. Okay, that is major difference. You look at the age. So AML you find mostly in elderly patients, 50 to 60-year-old, and we have different types, M1 to M7 with different lung translocation. And but what is highest yield and quite common here is one type, M3, that is promyelocytic leukemia, which has translocation 15-17, okay, 15 to 17. And what happens in this case? Actually, what happens is here is blockage of this retinoic acid, okay, translocates retinoic acid, and as you don't have retinoic acid, these cells does not mature Okay, does not mature. And one of the treatment of promyelocytic leukemia is you treat them with retinoic acid, and you see finally the cells will mature. Finally, will cells mature to neutrophils. Okay, they are myeloid lineage, and they will mature to neutrophils. And how it happens with this treatment? This is chemotherapy. What else? Another type of acute myeloid leukemia, guys, is monocytic leukemia. It's, whatever is mentioned in Pathology, actually. That is clinically common, guys. Clinically, you will find them. That's why it is mentioned in Pathology. But for exam purposes, you should know all acute myeloid leukemias, like 1 to 7. More common, I said that it is promyelocytic leukemia, and what else is important in acute promyelocytic leukemia? That is M3 again. You will find multiple hour rods there. And what is the function of hour rods? If you find numerous hour rods, guys, it usually activates coagulation cascade. Coagulation cascade. And what will happen if you have activation of coagulation cascade? There is increased risk of DIC. So, acute promyelocytic leukemia, this is type of AML, M3, it is medical emergency. Medical emergency, it is because patient might die with DIC, okay? So that's why it is medical emergency, and we treat this patient with a derivative of vitamin A. Okay, and why? They bind to the disrupted retinoic acid receptor and cause blood to mature, and they will become neutrophils. So it has good prognosis. Actually, it is you can treat this disorder, and patient won't die. But if you have problem with megakaryocyte lineage, okay, it depends how we make diagnosis of AML. It depends on what marker is positive, which translocation you find, which lineage of differentiation you find, okay? And one of the lineage of differentiation is megakaryoblast AML you should find. And if you have this megakaryoblast AML, you will have thrombocytopenia, right? And this clinically manifests with severe bleeding. And when we are talking about acute monocytic leukemia is very specific, guys, and you will never ever make mistake if you find patient with infiltrate the gums, they have bleeding gums, they have swollen gums, you can be sure that it is acute monocytic leukemia. Okay, it has very, very classical and specific picture. Swelling of the gum, whatever relates to the gum is monocytic leukemia in this AML, when we are talking about AML. And megakaryocytic leukemia, here comes one important information, and I want you to pay attention. Guys, acute myeloid and lymphoid leukemia. You know that, right? Acute acute lymphoblastic leukemia, you find usually it has significant association with Down syndrome. So, patient with Down syndrome has a high risk of developing acute lymphoblastic leukemia, but after age 5. But Down syndromes before age 5 has high risk of acute megakaryoblast leukemia. Okay, that is high yield information. So Down syndrome, if your patient has Down syndrome, and there will be mentioned after age of 5 and before age of 5. So after age of 5, you should know that they have risk of developing lymphoid, acute, both is acute, but after age of 5 is lymphoblastic, and before the age of 5, like children with Down syndrome are at high risk of develop acute megaloblastic leukemia, okay? That is also important. Also, guys, when we are talking about AML, they have a high association with myelodysplasia. Okay, myelodysplasia. This is lymphoid, right? Yes, lymphoid. When we are talking about AML, the one type is related to dysplasia, and what's in it? The dysplasia, what is? We have myelodysplastic syndrome. Okay, myelodysplastic syndrome is generally AML following myelodysplastic syndrome. Generally. And here you should know what is myelodysplastic syndrome. Myelodysplastic syndrome is associated with monosomy involving chromosome 5-7. That is not important. But what you need to know, myelodysplastic syndrome, you need to differentiate from acute leukemia. And how? In myelodysplastic syndrome, guys, you have dysplasia. Okay, that is straightforward. But how we differentiate from acute? You have blasts. You need to find blasts uh, above more than 3%, guys. And why do you need to know, remember this 3%? Because normally all of us have blasts, but it should not be greater than 1 to 2%. 1 to 2%. If you have greater than 2%, that is more likely myelodysplastic syndrome. And what happens here? Um, you will find the myelodysplastic syndrome usually you will find after treatment, okay, after chemotherapy usually. Particularly, patient has exposure, in history, patient have exposure of alkylating agents. Alkylating agents, chemotherapy and radiotherapy usually cause myelodysplastic syndrome. And secondarily, this myelodysplastic syndrome will lead to will cause acute myeloid leukemia. And why? It increased blast. There is increased blast, but from 3 to 20. 3 to 20. Above 20 is already acute. So that's here is important to measure number of blasts. All right. So how we differentiate the acute myeloid leukemia from myelodysplastic syndrome. In both cases, you have blast, but in blast you have from 3 to 20%, and above 20 is already acute. And that's why you have increased risk of developing of acute myeloid leukemia from myelodysplastic syndrome. You understand, right? In both cases, you have blast, and it is very easy to keep going this proliferation. And finally, myelodysplastic syndrome will lead to acute myeloid leukemia. Patients, what are you expecting to be cause of death? Cause of death in this myelodysplastic complication of myelodysplastic syndrome is acute leukemia, but cause of death will be infection. Okay, cause of death, patient most commonly die from infection or bleeding or progression to acute leukemia. Okay, and the question will be when they progress. What happens? No. Question is actually what is complication of myelodysplastic syndrome? No, yeah. And you should know that complication of a myelodysplastic syndrome is AML, and cause of death will be this. Okay, and what is cause of myelodysplastic syndrome? Causes is usually chemotherapy and radiotherapy. So when you are talking about acute myeloid leukemia, you should talk about myelodysplastic syndrome as well. That was about myeloid lineage. You will find Fagot says all these differentiations you should know, guys. So you will read it and memorize. I will send it as well. Now, when we are talking about lymphoblast ALL is important as well. ALL is classified according to the phenotype, and it is pretty straightforward. Why? ALL is acute lymphoid leukemia, and when we talk about lymphoid, we have T and B cells, right? T and B cells, so it's very easy. In both cases, and Burkitt leukemia, Burkitt lymphoma is the same, right? Burkitt lymphoma. But it is discussed here because you have both forms. You will find changes in peripheral blood as well as in lymph nodes. Does not matter if it is T or B. In both cases, TDT will be positive. Why? Because TDT is positive in blasts. All right. And T cell antigen and B cell antigen we have that helps us to differentiate between T cell and B cell leukemia. When we are talking, guys, about ALL, in Burkitt leukemia, you don't find blasts, guys. For that reason, TDT is negative, okay? And Burkitt lymphoma also is B cell lineage, so T cell will be negative as well. It is not difficult, it is quite easy. This is chronic one, but now I'm talking still about acute one. Did I mention this? I mentioned this. Yes, I forgot. Monoblasts and monocyte positive for neurospecific annulase. That is how they look. Monoblasts, okay? This is our road, what you find in AML, and that is general picture of acute leukemia, where you should find blast. So ALL, unlike acute myeloid leukemia, you should find mostly in children. Okay, ALL you find in children. And what is important here? Let me check on the high yield information here. Guys, when you are talking about ALL usually has very good prognosis, but you should know that there are two forms. Two forms means that is translocation. We have two forms based on translocation. Translocation like 12 to 21, and another form, can you hear, guys? That is noise. Can you hear me, guys? Shall I continue?
Yes.
Okay, it is very noisy here, but I will try to talk loud. Two forms based on translocation. One translocation is 12 to 21. That has very good prognosis, but if you find translocation 9 to 22, that has very bad prognosis. And why it is related to bad prognosis? 922 translocation means that it is Philadelphia chromosome, okay? Philadelphia chromosome. And Philadelphia chromosome shows this translocation between 9 and chromosome 22. And Philadelphia rearrangement is another name. It shows very bad prognosis. Why? This Philadelphia chromosome you find in chronic form, in chronic myeloid leukemia. And chronic myeloid leukemia is very, very aggressive usually. And wherever you find this translocation 922, it means that it has very, very bad prognosis. Okay? That is important. If you need to identify what is the prognosis of the patient, you look at the translocation in case of ALL, okay? And ALL you find in children most commonly, and you look at the translocation. 12 to 21 is good, 9 to 22 is bad, okay? And as for T cell ALL, you find in teenagers, guys, so pay attention that patients will be 15, usually 16, okay, at this age if you find usually the TLL, TALL, and it has good prognosis as well. But what can differentiate this diagnosis is you should find thymic mass as well. Teenagers and thymic mass and leukemia is straightforward, and you can make diagnosis of TALL, okay, acute ALL. So that was about acute leukemias. We talked about myeloid leukemia and lymphoblastic leukemia. Lymphoblastic leukemia more common is in children. Myeloid leukemia is more common in adults, but we have some forms depending on the differentiation of lineage, which you can find in children, particularly with which patient? Patient with Down syndrome. Okay, Down syndrome. ALL, you find guys in Down patient with Down syndrome after the age 5, and before the age 5 you should find megakaryoblast, acute megakaryoblast myeloid one. Okay, myeloid one. So Down syndrome and before and after the age of 5 is high yield information actually in this. Now let's move to chronic leukemias. What you need to know about chronic leukemias, guys? Chronic leukemias, as I told you, you mentioned chronic myeloproliferative disorders and chronic lymphoproliferative disorders. Now, when we are talking about myeloproliferative disorders, it depends. Chronic means you should find matured cells, okay, matured proliferation of this myeloid lineage. Depending on which lineage proliferates, okay, you will have appropriate disease. So if you have proliferation of myeloid lineage, you will have chronic myeloid leukemia. If you have proliferation of erythroid lineage, you will have proliferation of red blood cells and you will have polycythemia vera. If you have proliferation of matured megakaryocytic cells, you will have essential thrombocytosis. Okay, this is malignant. All these forms, guys, are malignant. Okay, CML, polycythemia vera, essential thrombocytosis, and idiopathic myelofibrosis. Idiopathic myelofibrosis, idiopathic means you don't know etiology, we don't know where it comes from, but you have idiopathic proliferation of fibroblasts. So that is 4 forms of chronic myeloproliferative disorders. How it looks when first disorder is CML. CML. CML is, guys, you see, chronic myelocytic leukemia. In that case, you will find matured proliferation of bands and neutrophils, okay, bands and neutrophils and myeloblasts you should find as well, few myeloblasts, but differential diagnosis is important here between CML and reactive leukocytosis. Reactive leukocytosis. How do we differentiate? Another name is reactive leukocytosis is leukemoid reaction. Okay, leukemoid reaction and CML. Differential diagnosis to make between them is really high yield. And how do we differentiate? On blood smear, they look very similar, but what really helps is this one. Translocation 9 to 22, that is Philadelphia chromosome, okay? Philadelphia chromosome is translocation 922. You should find massive splenomegaly in CML, and also, guys, in CML you find basophils as well, okay? Basophils as well, and basophils are positive for eosinophilia and basophilia. High, basically increased number of basophils you should find. And how do you know if it is normal basophils, and how do you know it is malignant basophils, right? If you know this with lab score, maybe, right? Lab score. Let me check here. Nowadays, we don't use this score. Nowadays, we don't use just fill out the translocation, cytogenetic information. But in books, you have this marker, and it is important. Oh my God. Guys, give me 10 minutes break, okay? I hope they will stop and I will continue.
Sure.
Okay. Guys, are you here?
Yes, doctor.
Okay, I will switch off the camera, right? Okay, what I was talking about CML, right? CML. CML, yes, it is chronic myeloid leukemia, and you should know that we need to differentiate from myeloid leukemia reaction. Leukemia reaction, how do we know? In both cases, you find basophila, increased basophila, and you see this is basophils. And how do you know? Lab score, yes, I remembered it correctly. Lab score. Lab score is got usually it is increased in inflammation, acute inflammation. And in inflammation, because basophils usually fight with microbes, right, and infection. But in this case, as it is malignant, the purpose of the basophils is not to fight against infection, right? It is purpose is just to proliferate. And prognosis is quite bad in this case. But that is old way of differentiation. Okay, lab score we don't use nowadays, but you should know that lab is negative if it is malignant, and if it is positive if it is leukemoid, it is benign. But basically, what we use here is this translocation. Okay, you should find Philadelphia chromosome. If you find Philadelphia chromosome, that means it has very bad prognosis, and quite bad it is. Uh, Also, guys, what is important here? Um, Where is this? I want this one. CML we talked about, and next disease I did not put here images, but you will see in Golian you have very good images of it, and in first aid as well. And in handout what I was said. What is polycythemia vera? Polycythemia vera, guys, is malignant proliferation of red blood cells. And do you remember in CML and in polycythemia vera, you need to make differential diagnosis between benign counterpart, like reactive leukocytosis in this case, and in the case of polycythemia vera, reactive polycythemia. Okay, reactive polycythemia. In this case, we look for this um, translocation. And in polycythemia vera, usually here is what type of myeloproliferative disorders you know, and what is characteristic mutation. Mutations you should know. And that's why I opened chronic myeloid leukemia again. Granulocytes are dominant cells. Mutation is Philadelphia in 95%. Here, polycythemia vera and essential thrombocytopenia is positive for JAK2 mutation. JAK2 mutation. And myelofibrosis is also for disease. Dominant cells are megakaryocytes, and JAK2 mutation you find only half of the cases. Okay, so JAK2 you can memorize in the case in relation with the polycythemia vera and essential thrombocytosis. Polycythemia vera is quite interesting disease, guys. And I will tell you how you make diagnosis of it. Clinical picture of polycythemia vera is quite important. Why? Uh, Viscosity of the blood usually increase. High viscosity you find. As you have too much erythrocytes, polycythemia, you have this patient is prone to developing thrombosis. Okay, so most common cause, if you have a question, what is most common cause of Bad-Chiari syndrome? And Bad-Chiari syndrome, maybe you remember from um, uh, venous thrombosis disorders. Do you remember? There was Bad-Chiari syndrome. This is when you have thrombus in hepatic vein. thrombosis of the hepatic vein is actually Budd-Chiari syndrome. And question is, what is the most common cause of Budd-Chiari syndrome? Most common cause is actually polycythemia vera. And what is complication of Budd-Chiari syndrome, guys? If you have, for example, thrombosis in hepatic vein, what will be complication? It will result in infarction of the liver. So polycythemia vera has complication of infarction of the liver. Okay, one of the complication is this. Usually, if you find this patient, it's very easy to recognize, but because they have flushed face, red face, they have a lot of red blood cells, they have itching after bathing. Also, that is high yield clinical symptom. For example, patient will notice that they have itching, particularly after bathing with hot water. Okay, hot water. They have severe itching, and this is symptom actually related to the polycythemia vera as well. All right, why? Because along with red blood cells, you have this. You also have extra mast cells. Okay, mast cells, and these mast cells they granulate and they release histamine, and this patient will have itching. Okay, so with polycythemia vera, you should know JAK2 mutation. Okay, you should know that mature myeloid cells proliferate in this case because it's a type of chronic myeloproliferative disorders, but dominant lineage is red blood cell, dominant lineage. And clinically, hyperviscosity, which I mentioned already, and hyperviscosity is major cause of Budd-Chiari syndrome. What is Budd-Chiari again? It is thrombosis in hepatic vein, which has complication of liver infarction. Flushed face and itching after bathing, that is also typical to polycythemia vera. Treatment, what do you think can be treatment? We don't have any other treatment, guys, only phlebotomy. Okay, phlebotomy, you should once again remove blood, decrease red blood cell mass somehow. So phlebotomy is only treatment in this case. Death usually come within a year. Okay, so it is very aggressive disease. But polycythemia is not very straightforward to diagnose. You need to make differential diagnosis because we have, as I mentioned, reactive polycytosis. Okay, reactive polycytosis. No, polycythemia. Sorry, polycythemia. What is polycythemia, guys? Imagine erythropoietin. You know what is, right? Erythropoietin. So, in two cases, you might have this reactive polycythemia. One case is if you go to the mountain, for example, where you have this low pressure of the O2. Okay, in that case, you have in this condition, you have low oxygen, right? Hypoxic condition, and therefore that reason, erythropoietin release will be increased. And this erythropoietin increase finally will lead to polycythemia. That is one condition. And second condition is if you have tumor, for example, in case of renal cell carcinoma. Renal cell clear cell carcinoma is the same. If you have renal cell carcinoma, they have paraneoplastic syndrome of producing erythropoietin. Okay, these tumor cells produce erythropoietin, and this increase in number of increase in erythropoietin production will lead to reactive polycythemia as well. So the reactive polycythemia is paraneoplastic syndrome of renal cell carcinoma. That is what you should know. Differential diagnosis in case of CML and in case of polycythemia vera with this leukemia reaction and reactive polycythemia. These two is important. Now, essential thrombocytopenia, what happens in this case? Essential thrombocytopenia is actually here is, guys, proliferation of JAK2 mutation is there, and I mean, it is quite a big disease, and I don't want to talk much about it. Mm, clinical symptoms. What you need to know about essential thrombocythemia, guys, in this, what is high yield and confusing is both you should find bleeding and thrombosis. And how come that you find bleeding or thrombosis? Uh, Platelets will not be functioning there, right? But you have the two problems you have with platelets. Either you don't they don't function well, or they are over functioning. Okay, over functioning, and depends on what will be clinical cause. You will have bleeding or thrombosis. But it is possible that in essential thrombocytopenia, depending on the stage, you will have this bleeding as well as thrombosis. Okay, that is essential thrombocythemia. It's there's written a lot, but you don't need much about it. Clinical picture, if you know, amputation, if you know of it, it is enough. And last condition is one myelofibrosis. Myelofibrosis. In that case, you see, you have fibroblastic proliferation and megakaryocytes also proliferate there. And wait, huh, complication of myelofibrosis is you should find dry tap, guys. Dry tap you should find there. Dry tap means finally what is a complication? It stops completely. It stops production only of red blood cells, and what is specific in myelodysplastic syndrome, you have excess production of PDGF, and PDGF, you know, it is strongest. It's a growth factor that will lead to fibrosis. Okay, and finally, in myelofibrosis, you will find complete fibrosis of bone marrow, and you won't have any production of red blood cells. And treatment in this case is only transplantation. Without transplantation, people won't survive. And also, you should find splenomegaly in myelofibrosis as well. That is, guys, about chronic processes, but chronic myeloproliferative disorders. But how quite different is chronic lymphoproliferative disorders. Lymphoproliferative disorders is very interesting as well. This is myelo. Chronic lymphoproliferative disorders is smart cells. You see, smart cells is important here. Now I'm talking about lymphoproliferative disorders, right? Lymphoproliferative disorders. First disorder is chronic lymphocytic leukemia. Lymphocytic is important because it is chronic, and for that reason, you should know there is matured lymphocytes, right? And as for chronic lymphocytic leukemia, you should know synonyms. Synonyms will be asked that CLL and SLL is the same. Small lymphocytic lymphoma, as I mentioned already. It also chronic lymphocytic leukemia is more common, guys, in adults. Okay, most common cancer is in adults. If it is B cell and T cell, that you should makes difference. Okay, chronic lymphocytic leukemia. If it is B cell lineage, if you find naive B cells, CD20 should be positive. You know that CD20 is positive in B cell, and also as you see on this picture, how can you make differential diagnosis of chronic lymphocytic leukemia? SMART cell. SMART cell, if you find that is specific sign of B-cell leukemia. Also, what I need to know here, complication, guys, stages are important, okay? Stages. CML, lymphocytic leukemia, small lymphocytic lymphoma. Do you remember? Here, pay attention. Small lymphocytic lymphoma means that you should find this proliferation in lymphocytes as well. lymph nodes as well. So clinical symptom of chronic lymphocytic leukemia is generalized lymphadenopathy. That is how we make diagnosis. Elderly patient with generalized lymphadenopathy, on blood smear you find smudge cells. That is chronic lymphocytic leukemia, and you should know also that most common leukemia overall is chronic lymphocytic leukemia. CLL is most common. You will find in elderly, and you should know also that there is stages. And what is stages? Uh, Usually, this chronic CLL has high risk of transformation to more aggressive diffuse large B-cell lymphoma. Sorry, this transformation is called Richter transformation. You will have this question as well. Richter transformation is transformation of CLL to diffuse large B-cell lymphoma. Also, second complication in this case is hypo gamma globulinemia. Why? Because B cells does not function well, so immunoglobulins you won't have there. And so most common cause of death in case of CLL will be infection. Infection in elderly, most common cause of death will be infection. Association, guys, is autoimmune hemolytic anemia. Do you remember if you read this hemolytic anemia, normocytic anemia? There was autoimmune, one and cold. Here both type. Association is association. You will find these hemolytic anemias as well at the beginning, in the beginning, okay, of the disease. Because finally, final stages, it will lead to B-cell lymphoma, and most common cause of death will be infection. What else, guys? No stages you will read. This is just clinical course. Not that important. And second type, you see here, here is cell. Here is cell. Second type of chronic lymphoproliferative disorders after CLL is hairy cell leukemia. Hairy cell leukemia is mature B cell, you find, and whatever you see, this is hairy cells. Literally, this type of cells, if you find, that is hairy cell leukemia. It's very straightforward to make to make diagnosis. Lymphadenopathy usually absent in hairy cell leukemia. It is real leukemia, matured B cell you find, but unlike CLL lymphadenopathy, you don't find here. But myelofibrosis you should find here. Bone marrow fibrosis is very peculiar to this hairy cell leukemia. So dry tap you should find in bone marrow. Dry tap is when you have myelofibrosis, fibrosis in bone marrow. What you see on the biopsy is dry tap. So that is hairy cell leukemia. Usually, if you treat, excellent response, it has good prognosis. It has lymphadenopathy. You should not find, and splenomegaly you find. Okay, why? Because this hairy cells usually accumulate in spleen, and spleen enlarge in size. Third type, you see the X-ray picture is here. This is adult T-cell leukemia that is also rare because this is only type of leukemia that is related to virus. Okay, virus-induced leukemia it is, and this virus usually is HTLV, HTL virus, human T-cell leukemia virus 1 is okay, and you find it in Japan usually. It is quite anyway, it is not common, but wherever you find it is in Japan and Caribbean. What you should find, adult, you see, patient will be adult. T-cell leukemia, it is lymphoproliferative disorder. Lymphoproliferative disorders, you have B and T cell. B cell is CML. Hairy cell is also B cell, and now we are talking about T cell. T cell leukemia is CD4 cells you should find. CD4, you know it already. And clinically, what you see, guys, lytic lesions, you see there, lytic lesions, punched out bone lesions, you should find, with hypercalcemia. That is important. Adult T-cell leukemia is characterized with the lytic lesion. You have bone resorption. And as bone resorbs, actually, calcium level will increase. So in that case, you should find hypercalcemia. Hepatosplenomegaly, definitely. Generalized lymphadenopathy, you should find, and skin rash. Okay? That is what you should find in adult T-cell leukemia. And as you know, it is virus-induced. It has very, very good prognosis with chemotherapy. Patients usually don't die with it, but very bad prognosis you have with chronic lymphocytic leukemia subtypes. Patients die with infection, you know that. And first type, guys, T-cell leukemia is mycosis fungoides, and you see here, you see here this Sézary cell, you see, Sézary cell. Sézary cell is there, and microabscesses, that is microabscesses, and grossly you should find this rash. Okay, this is, if you find this type of rash, that is very, sorry, I'm sorry guys. So last part of chronic myeloproliferative disorders is mycosis fungoides, which you find in T-cell leukemias as well. It is similar to CLL and SLL, you know, chronic lymphocytic leukemia and small lymphocytic lymphoma. Mycosis fungoides is T-cell, adult T-cell lymphoma is another name, if I am not mistaken. And what happens is, mycosis fungoides, guys, what you need to know here, Sézary cell, very pathognomic to it. On morphology, on blood smear, if you find Sézary cell, that is important. Lymphocytes you should find that are CD4, okay? And these lymphocytes usually infiltrate skin. This is skin lesion, skin lymphoma is because it's fungoid. And in skin you should find this CD4. And accumulation of this abscess is what you see. That is accumulation of T lymphocytes. Okay, mycosis fungoides is quite easy. Nothing difficult here. Next condition, guys, I will continue, and here comes lymphomas. That is Rosari. This is hairy cell. This is CML. Just we know it. Lymphoma, Hodgkin lymphoma and non-Hodgkin lymphoma. Here comes, guys, this image. I love this image. Origin of Hodgkin lymphoma. Lineage of differentiation. B cell differentiation is here. Okay. You see here is blood. So blood get a bone marrow, for example. In bone marrow, you should find pre-B cells. Pre-B cells, that is ALL. Do you remember? This is acute lymphoblastic leukemia B cell. Then, if it goes out from this bone marrow in the peripheral blood, they become naive B cells already. And if you find the naive B cell, this will be chronic. And what is the difference between acute and chronic? Acute is blood. You should find a lot of blood in bone marrow and peripheral blood. And if you find matured B cells, that means it is CLL, chronic. How do you know? Marcus is 5, 25, 23. That is Marcus, and you will find it in book. Then, if this B cells goes to lymph node, this is lymph node, right? And lymphomas now, when we are talking about lymphoma, Hodgkin and non-Hodgkin lymphoma. Hodgkin lymphoma is completely different. Okay, now we are talking about non-Hodgkin lymphoma, and non-Hodgkin lymphoma is B cell in origin. Then this naive B cells goes to the lymph node. If you have proliferation of B cells in the lymph node, we have different types of lymphomas based on the area, okay, location. If it is If arise in follicle, you will have follicular lymphoma. Follicle location, either you have proliferation of B cells in follicle, or in mantle zone, or in marginal zone. Okay, that is histology of lymph node. Histology of lymph node. If you know, this is easy. So different type of non-Hodgkin lymphoma: mantle zone lymphoma, follicular lymphoma, marginal zone lymphoma. Burkitt lymphoma, as we already talked, Burkitt lymphoma you find in follicle as well. Okay, and DLBCL is diffuse large B cell lymphoma, most aggressive non-cell lymphoma you should find in follicle of the lymph node as well. Okay, so in follicle, in germ cell, a germ cell tumor they are, as a germ cell germinal center, you should find these three types of lymphoma. Okay, follicular lymphoma is quite aggressive, by the way. Now a general overview, big picture of B cell differentiation I'm talking about. Okay, B cell starts with acute, then chronic leukemia, then here lymphomas, and B cells produce plasma cells, right? And you have also tumors that arise from plasma cells and plasma blasts. Tumors that arise from plasma blasts. Blasts is Waldenstrom macroglobulinemia and matured plasma cell, okay, already matured one. That is blast. And matured one is multiple myeloma. Okay, that is tumors you should know about B cell lineage. And you go through details what is follicular lymphoma, what is mantle cell lymphoma, and usually these lymphomas are indolent, okay, indolent in nature, very slow growing. But out of this, most malignant is DLBCL. And chronic process, a chronic CLL, if goes to DLBCL, this is the Richter transformation. Okay, we told it already. Okay, that is, guys, classification, broad one, and differentiation. Now, if we talk about Burkitt lymphoma has different subtypes. And what is these different subtypes? Wait, that is Hodgkin. Let me see. I'm non-Hodgkin. Oh. Burkitt lymphoma, yes, based on translocation. Is it written here? Translocation? No. This is clinical forms, guys. Burkitt lymphoma has subtypes. And please, this is important. African type, clinical form, it is African, endemic, and sporadic is non-endemic. And aggressive form you find in HIV infected individuals. Burkitt lymphoma, guys, it is associated with EBV infection. EBV caused lymphoma is Burkitt lymphoma. You should know it. Okay. And you see, in Africa, usually in African children, was discovered this ABV. Okay, ABV was studied in African children and Burkitt lymphoma. Usually, you find it in children, definitely in young adults. In elderly, you don't find it. That is classical and important clinical information. Maxilla and abdominal organs like kidney, ovaries, and adrenal glands are involved. Okay, they have swelling of maxilla. This involvement of organs is typical to African form. Typical to African form. But here, it affects children and young adults as well, but clinical form is different. Involvement of ileocecal and peritoneum. So abdominal symptoms you have in sporadic one, and in African syndrome you should definitely have maxilla involvement. Okay, okay. And that is an aggressive forms. What is written here? Aggressive forms usually you find in only 25 cases. This is Burkitt lymphoma is not aggressive, by the way. You can treat it, but we have some aggressive forms which not treatable. It lead to death. What you see, Burkitt lymphoma has this starry sky appearance. This is Burkitt lymphoma, this is Hodgkin lymphoma. Starry sky appearance, you will have this question on morphology, how Burkitt lymphoma looks. Starry sky, wherever you find starry sky, it's Burkitt lymphoma. What you see here, guys, this blue background, all these cells are malignant. Okay, all these cells are malignant. And these cells are actually macrophages, okay? Stars actually are macrophages. And difference you need to make between Hodgkin lymphoma, it is not difficult to make difference between Hodgkin and Burkitt lymphoma, but you see here, this is peculiar to Hodgkin lymphoma. That is Reed-Steinberg cells. That is how we make diagnosis. But pathogenesis, guys, you see this background here, right? This is lymphocytes as well, but they are not malignant. Malignant cells here in Hodgkin lymphoma are only these Reed-Steinberg cells. Unlike in Burkitt lymphoma, all these B cells are malignant. Okay, this difference, to make this difference is also important and quite helpful. So Burkitt lymphoma, you will read. I, I don't have this image, but it's okay. Differential diagnosis, guys, in leukemia and lymphoma is important. You remember CML to make differential diagnosis between a leukemoid reaction. You remember also polycythemia vera vs reactive polycythemia, and we have follicular lymphoma. And here comes already third differential diagnosis, reactive follicular hyperplasia. Okay, reactive follicular hyperplasia. This is also important, and that is also what is most commonly misdiagnosed in Georgia, for example. Follicular lymphoma misdiagnosed with reactive follicular hyperplasia. How do you differentiate? Monoclonality, guys. Clonality, do you know? We study this. Cells are monoclonal if it is tumor, and cells are polyclonal if it is hyperplasia. And this is very high yield information, and is discussed. You studied it in general pathology, maybe you remember in neoplasia chapter. How? Monoclonality and polyclonality. We measure it by light chain, immunoglobulin light chain ratio, right? Do you know we have immunoglobulins, which is produced by B cells, and this immunoglobulin has light chain. In the light chain, we have kappa and lambda, and normally this ratio should be 1 to 3, 3 to 1, 3 to 1. And if it is 20 to 1, then that means tumor is monoclonal, and definitely it will be lymphoma and not hyperplasia. What type of mutation you should find, guys? If it is lymphoma, follicular lymphoma, you should find BCL2 expression, BCL2. And if it is hyperplasia, BCL2 won't be expressed. Also, that is markers, what is helpful, but we look as well at architecture. Architecture. Architecture means, guys, normally, lymph node has a very regular appearance, okay? Preserved lymph node architecture, the germinal centers you have, and mantle zone and everything is very clear. But what you see in follicular lymphoma is multiple follicles you see, and the architecture of lymph node is completely disrupted. Okay, so it is helpful, but sometimes it is not very prominent. For that reason, you need to check BCL2 expression as well as clonality. Also, guys, the last one you need to pay attention is tingible body macrophages. Macrophages in germinal center. In normal, no, but in benign condition, if it is benign hyperplasia, follicular hyperplasia, you have tingible body macrophages. Okay, and they eat usually these bad B cells. B cells, if behave bad, for example, and has this abnormal markers or something, they digest. Okay, they eat these B cells. And the tangible body macrophages in hyperplasia is normal to find, but this tangible body macrophages you should not find in follicular lymphoma because it is malignant. Okay, in germinal centers you just find the proliferation of lymphocytes. So that is what I talked about differentiation, right? Differential diagnosis 3 is really high yielding hematology. CML, polycythemia vera, and follicular lymphoma. Follicular lymphoma, Hodgkin lymphoma, I want to talk about now. Hodgkin lymphoma, WHO classification of Hodgkin lymphoma. In Hodgkin lymphoma, we have different types, you see. Nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, and lymphocyte predominant. Whatever is given here, that is all you need to know. Okay? But important here is that most common, if question is what is the most common form of Hodgkin lymphoma, is nodular sclerosis. Most common form is nodular sclerosis, and which one has the best prognosis? Best prognosis has nodular sclerosis as well. Excellent prognosis is given here. Lowest number, which has best prognosis and which has worst prognosis. Lymphocyte depleted has worst prognosis, okay? Poor prognosis here is given. Excellent, that is more common and excellent prognosis it has. Here is markers, most of them has the same markers of differentiation, only lymphocyte predominant. Best prognosis it has actually. Okay, nodular sclerosis is most common, has good prognosis, but lymphocyte predominant, non-classical Hodgkin lymphoma. It is not common, but best prognosis this has. Okay, lymphocyte predominant. Lymphocyte predominant, lymphocyte rich, and lymphocyte depleted is completely different, guys. Here helps these markers. I don't think you have to memorize, but if you look and understand, it is very good. But from Hodgkin lymphoma, you should know this one. Rich Steinberg cells, but those cells are not malignant compared to starry sky appearance, and different types. Okay, types of Hodgkin lymphoma, types of Burkitt lymphoma. That is what you need to know. Now, that one, do you remember we talked about these lymphomas? You go through all this detail. What is DLBCL? You will read this most malignant and all this terrible clinical picture you have. And now we need to discuss the plasma blast disorder and plasma cell disorder. What is important here? Lung cancer cell histiocytosis, lung cancer histiocytosis, lung cancers are macrophages. You know, we have histiocytosis, we have as well. This is from Pathoma. Rare, they are very rare disorders. They are letters SPI, and this is very rare. Whatever is written in Pathoma is enough. Lung cancer, histiocytosis, you will read yourself. But here, what is important from these two, you should know what is multiple myeloma. What is multiple myeloma, guys? Multiple myeloma is a malignant proliferation of plasma cells, as you see, these matured plasma cells. You should find, and you know, uh, you studied here in hematology, but it is most common primary malignancy of the bone. Okay, musculoskeletal pathology. When you do, you will learn this multiple myeloma there. So it is most common primary malignancy. You know what is the difference between primary and secondary malignancy. Secondary is metastatic tumor, and primary is when it arises from the tissue, right? So most common primary is this. In serum, you should find interleukin 6, okay? Rank L is important there. which induce the plasma cell growth. So what that is pathogenesis. What induce plasma cell growth and immunoglobulin production? This is interleukin 6. And features, guys, on X-ray you make the diagnosis, okay. You know it is lytic lesion. Plasma cell produce these interleukin cells which lead to proliferation, secondary proliferation, and it activates osteoclasts. As you have activation of osteoclasts, usually you find on the skull. Okay, on the skull, the it resorbs blood and punched out lesion you will find on the skull and vertebra. That is very peculiar to multiple myeloma, and as it is lytic lesion, calcium will be increased. So clinically, you should find bone pain, severe headache. They have headache, skull is painful, and they have hypocalcemia. Classical case, I'm saying, because multiple myeloma is very difficult to make that diagnosis. Clinically not, but diagnostic features you should find, guys. Immunoglobulin G, okay. M spike, serum protein. In serum you should find protein, and you should see M spike present in serum protein electrophoresis. Electrophoresis, maybe you know what is, and when you check the proteins in serum, you will see normally you should not find this M spike, but if you find M spike high gamma globulin that is peculiar to multiple myeloma. So classically, due to much immunoglobulin G and immunoglobulin A, that is two immunoglobulin, please memorize this. Immunoglobulin G is majority and immunoglobulin A is minority, but this M spike is caused by either G or A. Uh, you see, you don't have immunoglobulin, guys. Plasma cells don't function well. For that reason, you have increased risk of infection. As you have increased infection risk of infection, that can lead to secondary cause complication. You might have, and cause of death can be infection. On blood smear, rouleaux formation you should find. And what is this rouleau? This is red blood cells usually as you have increased serum protein, okay, increased serum protein and decreased charge between red blood cell makes stacks, okay, they pile up. And call this rouleaux is a French word actually. It's cylindrical packets of coins you should find. And you will see, and I don't have picture now, but rouleaux of red blood cell, it is very typical to multiple myeloma. Also, for that reason, as you have formation of the coin stacking formation of the red blood cell, you have anemia. Plasma cells crowds out bone marrow to little red blood cell synthesis. Yes, anemia is one of the prominent feature of multiple myeloma. What else, guys? Others are many disorders that are not so important. But what was high yield actually I mentioned here, this differentiation, multiple myeloma. While the term macrogamma globulinemia you will read from Pathoma, Pathoma is not very good for everything because very little, very few is written about lymphomas. But if you know Pathoma and handout, it is absolutely enough. Okay, that's it.